So welcome back to part 3 of this 5-part series on spinal emergencies, and in this case we're going to be discussing Zinzan, who's a dog that's presented to you with an ambulatory paraparesis. So he's a 2-year-old male entire Labrador that presents to you with a peracute onset of a yelp, one running chasing a ball, initially reported by his owners to be paralysed at the time of the injury. You see him then 3 hours later and the owners felt that he's improved as he's now starting to weight bear in his pelvic limb. When you examine him, the only significant finding on his general physical exam is he's overweight with a body condition score of 6 out of 9. And on neurological examination, he's ambulatory paraparetic, worse in his left pelvic limb. He has absent proprioception to the left pelvic limb, delayed proprioception to the right pelvic limb with intact spinal reflexes. There's no pain on spinal palpation and his thoracic limbs and cranial nerves are all normal. So our plan of attack for him is to ascertain the onset and the progression. We'll then work out whether he's painful or whether there's pain and symmetry. Finally, we'll localise him, generate our list of differential diagnosis and decide if we want conservative management versus referral. So this is a video of him walking, and as you can see, there's very minimal movement in that left pelvic limb. There's maybe some degree of hip flexion, but otherwise he's just dragging it along as he's walking, and he's taking good stepping movements on his right pelvic limb, and his thoracic limbs look normal. So from the history, we know that his clinical signs were acute in onset and resolving. To work out his neurolocalization, we know that he's got absent proprioception on his left pelvic limb, delayed proprioception in his right pelvic limb with normal spinal reflexes. So we know then that if his spinal reflexes are normal, he has a normal L4-S3 spinal cord segment, so he must be a T3-L3 in localization. He's got a cutaneous trunky cutoff at the thoracolumbar junction, which helps us to narrow the localization down within T3-L3. So a little bit more specific. So it's like the lesion, if he's got a cutaneous trunky cutoff at the thoracolumbar junction, is going to be around T12, 13, T13-L1. He's got no spinal pain and he's slightly left lateralized. So now we've got our onset, progression, our localization. We can work out our differential diagnosis by going back to this severity versus time graph. With the acute resolving history, a traumatic event or a vascular injury to a spinal cord are going to be the most likely differentials. So trauma would include lesions like an acute non-compressive nucleus pulposus extrusion, because it's basically where a disc has exploded and traumatized the spinal cord and bruised it. And a vascular injury would include things like a fibrocartilaginous embolism, so when a blood vessel within the spinal cord has been occluded by something. So the question remains then, conservative management versus referral. So I think we've touched on this briefly about the differentials. This is an MRI of the dog and it shows this very patchy hyperintensity within the spinal cord. Now that's most likely going to be something like an FCE or fibrocartilaginous embolism, but sometimes it can be really, really difficult to differentiate other causes. So lipid embolism, if you've got an overweight Labrador, for instance, you think might have hypothyroidism, there's a potential that they could have a lipid embolism to the vasculature of the spinal cord. Verminous embolism, so lungworm, neoplastic embolism as well, which is why it's really important sometimes to ascertain whether these animals have got any systemic illness. These are all possibilities for causing an ischemic event to the spinal cord. We briefly discussed whether it could be an acute non-compressive nucleus pulposus extrusion, and this is when you get supraphysiologic forces on the disc, so often seen when animals are running or jumping or twist to catch a ball, and it just causes the pressure in the disc to exceed normal and the disc essentially pops, and a bit of the nucleus, which is the central part of the disc, gets fired out at speed and it hits the spinal cord. So you can see this middle disc on the MRI, on the picture on the left, has got a slightly less hyperintense center compared to the adjacent discs either side, and the spinal cord above it has got a slight hyperintensity to it, which would be consistent with bruising. So our differential diagnosis for this dog include an ischemic myelopathy versus an ANNPE. You can't differentiate between these diseases without advanced imaging, so an MRI scan is the best test you've got to visualize the spinal cord. If the animal's getting better, you don't have to image, you can just rest. And I've certainly seen cases before that have been referred initially paralysed in the back legs, but by the time they've got to us have been showing improvements in their movement. And with the history consistent with an ischemic event or an ANNPE, we've made the decision just to monitor the dogs. Even with MRI, it can be challenging as there can be an overlap in appearance, and sometimes we image these dogs, and even then looking at the imaging, it's difficult to differentiate between an FCE and an ANNPE. But does imaging change the management? Yes, it does. If there is an ANNPE or there's a suspicion of an ANNPE, this can leave a hole in the dorsal annulus, and it does predispose the animal to potentially extruding more material. So in these cases, having a period of rest to let that scar in the annulus heal over can be beneficial for them, just to avoid potential progression in the future. Alternatively, referral is always an option for these cases. If signs are not improving, i.e. from the onset to presentation the dog's static, if the signs are progressive beyond 24 hours, or if the animal is painful, which they shouldn't be with a vascular injury or an ANNPE, then it's certainly appropriate to refer these cases.